Let's go ahead and call the Public Health Subcommittee meeting to order. And stand for our invocation. Father, thank you for this day. Thank you for the efforts by all that to make these meetings possible. Thank you for the protection you afforded us. We ask for that same protection going home today. Thank you for the privilege of just being here in Jesus' name. Amen. Okay. Shelley, I'll let you do the roll call.
Okay. I'm going to have to do two roll calls, one for those that were not involved in an election and then one for those that were involved in the election. Those that just came out of an election, I need you to let me know if you want to be a part of this subcommittee. So, Mike Dobbins.
Here, yes.
Keith Austin.
Here.
Julia Coates.
Here.
Sean Crittenden.
Here.
Joe Deere. Rex Jordan. Daryl Legg.
Here.
Wes Snowfire. Dora Patskowski.
Here.
And then let me know if you want to be a part of the committee. Danny Callison.
Here, yes.
Johnny Kidwell.
Here, yes.
Joshua Sam.
Here, yes.
Mike Shambaugh.
Here, yes.
Melvina Shotpouch.
Yes.
E.O. Smith.
Here, yes.
Condessa Teehee. Victoria Vasquez. Okay, we have a quorum.
Thank you, Shelley. We have with us today from our Public Health Department, Ms. Lisa Pivek. She's the Senior Director of Public Health, and Dr. David Gann, the Medical Director. So we'll turn it over to them. Hello.
Thank you for having us today. It's good to see those of you that we've seen last time, and it's good to welcome the new counselors to the table and hope that we can provide you a lot of information about public health as we go through the process of today. What we do as a society collectively to assure the conditions in which people can be healthy, that is what public health does. And I have always looked at tribes as the original stewards of public health, because we take care of one another, we take care of families, and we take care of the earth. And those are the essential pieces of public health. And public health extends beyond health services. Education, social services, human services, all of those are involved in public health in some way or another. So we're working on cross-collaboratives to involve those departments or divisions more over the years to come. Before I get started, and I just have a few highlights on my report, but before I get started, I think it warrants a couple of things. We've had a pretty rough month, as you know, with COVID. And from the public health side, I want to thank the clinical staff at Cherokee Nation Health Services. Our hospital and clinics are working hard as they can to treat and care for our citizens. Our emergency department sees every person that walks through the door. Both inpatient and outpatient are working diligently to provide testing, vaccinations, and medical care. Our public health staff has been able to adapt quickly to COVID-19 roles of contact tracing, case investigation, answering calls from the public, and keeping the decision makers informed of the current community spread. And I want to thank those in public health who are also keeping the wheels turning on all the other things that have to happen every day. That doesn't stop. Grants, accreditation, all of those things have to be kept up. So I wanted to take a time to thank them. On my report, you have that, and I just want to highlight a couple of things related to COVID and one not. In June and July of this year, we did 1,527 case investigations. We did 14,266 follow-up calls, and our hotline call took 3,769 calls that we answered. Those numbers will look different the next time I'm here. They will have increased greatly. The other thing that I wanted to mention is we are very fortunate. Deputy Chief Brian Warner has been elected as you've probably seen, the chair of the Tribal Advisory Committee for Centers for Disease Control and Prevention for their committee, and it is really, I've been working with CDC for many, many years, and the progress that's been made in the short time that he has been co-chair and now chair is really telling. He has done so much work and CDC is quite proud of him, and so I wanted to mention that. I don't have any other things to mention on my report. If you have questions on the report, please be free to ask me. Feel free to ask me. You can call me. Otherwise, we're trying to keep you on time so that you're can get to your next meeting on time. Questions about my report?
Any questions for Lisa? Okay.
I'll
Dr.
turn it
Gann?
over to Dr. Gann now for the COVID update.
It's good to see everyone again. It's been a pretty rough month, pretty rough time since the last time we met. What Lisa said about our health services people can't be understated. They are working themselves very hard. So, globally, the numbers have kind of plateaued. I don't have a good graph for that, but we're looking at around 650,000 cases a day globally. And they're just hot spots around the world. The first surge we went through was kind of a wave that went over the whole planet. And now it's kind of a hot spotting. And the same thing's happening in the United States. All right. Where's my IT guy? Try that one. We'll get there. So the United States, we're mostly in the red again. That's over 25 cases per 100,000 people per day. This whole Delta wave kind of started in Missouri and then just spread out from there. Florida is still in pretty bad shape, over 20,000 cases a day, in Texas as well. So this is the curve for the United States, and you can see that over towards the end, we're starting to slow down. So we're still increasing, but at a much slower rate. Let's see, there we go. So over on this end. So hopefully we're going to peak in the next couple of weeks. And then for deaths, the deaths have really been dramatically low. We're still at just under 1,000 deaths per day, which is tragic, compared to our last surge when we were up to 4,000 deaths per day. And that's due to a lot of things. The vaccine is protecting people from dying. Our advances in treatments and caring for those who are hospitalized, and treatments before hospitalization that keep people out of the hospital, right? So it's working out pretty well. Oklahoma, the numbers can get really erratic. Today, the state reported a tremendous number of cases, and I haven't heard from them why. You can see the cases went down over the weekend, the first couple of days this week, and then they've gone back up. So Oklahoma is averaging 2,500 cases per day, which, if you look back in January when we peaked, we were over 4,000 cases a day. So not as much as we had before, and things maybe are slowing down. We'll just have to let this curve develop for a few more days. So here's the county level view of the state. You can see we're mostly in the red. Several of the top 14 counties listed on the right, they're in northeast Oklahoma. So we're taking the brunt of it here, and we have been for a month. The big problem, and what you hear about in the news, is the number of people hospitalized in Oklahoma. So this graph can be a little bit hard to interpret, because the number of people hospitalized is a function of not only the number of people who need to be hospitalized, but the number of beds that are available. And when beds aren't available, patients get shipped out of state and won't show up in these numbers. At Hastings Hospital, we routinely, on a daily basis, are sending people out of Oklahoma for hospitalization because there's no beds available in the area. But it's a good curve to follow, and as the governor allows hospitals to expand their capacity, then there's more availability, and those numbers will continue to go up. In Tulsa, we track the Tulsa numbers pretty closely because that's our primary referral center when someone needs to leave Hastings Hospital, either because of how sick they are or because we're out of beds. You've read and heard from Dr. Jones. We've expanded our hospital capacity at Hastings tremendously and are able to staff the beds that we've expanded to. Here's Oklahoma deaths. These are a little bit difficult to report. In Oklahoma, each chart for someone who's suspected of having died of COVID is reviewed by hand. So the dark blue are this is from the weekly epidemiology report. So the dark blue over on the right are deaths that occurred last week. And I think there were 85 deaths last week. So here's Cherokee Nation. Now, the data I'll show you now are just from Cherokee Nation Health Services. These are people who tested with Cherokee Nation. And this is a cumulative curve. So we had our big surge in December and January. Then in March, things calmed down. And then in beginning of July, middle of June, things picked up again. We went over 20,000 cumulative cases this week. Currently, we have 2,210 active cases. So this is cases per day. This graph starts in the end of December, and this was our peak, 200 cases per day. And then what we've been through this current surge. So every Monday is our busiest day. So I plotted those out with the numbers. Last Monday we had 290 cases just a few days ago. We're averaging 165 cases per day. Yeah.
I guess it'd be summertime maybe or not.
Yeah, so
Can't see it.
right here where the cursor is the first week of March. And here's the first week, or the end of June, right here, the last week of June. So we had a dry spell there. And these numbers that are too low to be seen, that's anywhere from, 2 to 3 cases in a day to 15. The next slide is a little bit, well, here's our 7-day rolling average of cases per day. So you can see we're at 165. The weekly number of cases is a little bit easier to understand when you're looking at these numbers. So back in the first week in January is when we peaked with 1,400 cases in 1 week. And last week we had 1,128. This 495 is the week to date. It's just, we have several days of tests left to collect. So you can see the steepness of the curve and how quickly we went from enjoying our work again to crisis mode as we went up. And that was part of the difficulty in this current surge is how quickly things went from almost normal to very bad. And to make those many adjustments in everything that we do in health services and throughout Cherokee Nation to adapt to the need. Now we're testing a tremendous number of people. So last Monday we tested 1,405 people. We're testing over 1,000 people a day, except for the weekends, over the last couple of weeks. Tremendous amount of human capital we use for that, as well as materials. Last week we tested 6,176 people, which was a record for the whole pandemic. And that's all that I have. We've been working closely with the schools on their mitigation plans and their response plans. We daily get calls from schools in our area asking for advice and recommendations on what's happening in their schools. We've got, I think one of the strong parts of our public health system is we've had relationships with most of the schools in Cherokee Nation for years. And so there's trust and bridges already built, which really helps us respond to what's going on today.
Yes, sir. Did you tell us how many was vaccinated up to this point?
I don't have the vaccination data here. Cherokee Nation and Dr. Jones has the number of people that Cherokee Nation Health Services has vaccinated. We get our data for the area for Northeast Oklahoma and for the state from CDC, and I didn't prepare that for today.
Dr. Gann, do we track how many individuals that have recovered from COVID, they're naturally immunized? Do we track those numbers?
The state has some estimates that they work with CDC on. So they do random surveys to test for antibodies in people, and they use that to estimate the number of people who have been exposed to COVID-19. The data is really hard to interpret because of those people who have antibodies, they can tell that it's from the virus and not from the vaccine, but they might have also been vaccinated. So we can't separate out this percentage of the population has been vaccinated and is immune, and this percent has been exposed, not vaccinated and immune. We can't really, we don't have data to describe that. Does that make sense?
Yeah.
Yeah.
I was just I always see vaccination rates,
Right.
but I never see immunization rates, which
Right.
would include those that are
Natural immunity.
recovered.
Yeah, so it's that crossover. How many people who are vaccinated or also have natural immunity on top of that? We don't have that.
Okay, thank you. Victoria?
Yes, Dr. Gann, if a person had their 2 shots, Pfizer vaccines, December and January, should they be looking to go get a booster shot now, and are they available in our clinics?
The CDC has approved routine booster shots starting September the 20th. So I don't know our absolute plans for when we'll turn that on in health services. The people currently getting additional doses of vaccine are those who are immunocompromised. So,
Julie?
Sorry. I had just a follow-up question, sorry. Could a person, or should a person go get tested for antibodies 8 or 9 months after they had those shots before they even consider getting a booster?
no. So the antibody tests that you can get now are they're positive or negative, there or not. They don't really give you a level. There are some tests that will do that, but we don't know how to interpret those results. Like if your level is here, you're protected, and if they're lower, you're not protected, or if there's none, even if you don't have any antibodies, there are other parts of your immune system that aren't measured through antibodies that could provide immunity. So there's no, when I'm taking care of a patient, there's no usefulness in that test in deciding whether or not to get a booster. Yes, ma'am.
Okay, Julia?
Thank you. Can you repeat that figure to me? I didn't catch it. That last week, we tested over 6,700.
6,176.
176.
Yes, ma'am. It's up
okay.
there on the
Okay,
graph.
yeah.
It's hard to read, sorry.
Yeah, okay. And then my second question is, I talked to somebody last week, and I've been reading this too, that they picked up on an article where it said that this pandemic by the fall may become not so much pandemic as endemic. And they thought that was a cute wordplay, and it meant ending, right? And so I explained to them that's not really what it means. Can you explain what endemic is and what your view is, if that is in fact where we're headed?
Yes, ma'am. So when a disease is endemic, it means it's present at a certain level in a population. So if I go to certain parts of Africa where there's malaria, there's a certain number of cases that they expect all the time. If we had a case of malaria in Oklahoma, just one single case, it would be considered an outbreak, right? And it'd be considered a public health emergency. So endemic is just that. Influenza that we have every year, it's going to be here, we know it's going to be here, we have a certain number of cases. So when the number of cases of a certain disease that's endemic goes up, then it becomes either an epidemic, and if it spreads globally, it becomes pandemic. And if it's localized, an outbreak is just an unexpected number of cases. Rocky Mountain spotted fever, we have a certain number of cases every month, and certain times of the year we expect more cases. So Rocky Mountain spotted fever is endemic to Oklahoma. So endemic means in as opposed to ending, right? Little Latin wordplay.
The one thing that we haven't heard about at all, and I guess maybe it's because of our practices, is the flu. I mean, man, that was, wasn't a killer, but it did kill a few people, but it really afflicted a lot of our population, and now you never hear anything about it.
Yeah, there's a lot of theories about why the number of people with influenza last season was so low. The same thing with RSV. And most people will attribute it to as mitigation measures we have for COVID also work to prevent people from getting the flu. We also know that it's, even though you might test positive for 2 different viruses at the same time, that there's only one virus that's making you sick. But having COVID can prevent you from contracting the flu, right? And so there's all that, we don't really know for sure. But the concern is, like what we've seen with RSV this year, that so few kids got exposed last winter that they didn't develop any immunity. And so we had kind of a surge during the summer, and currently there's a lot of RSV present in our community. Did I answer your question? Yes, okay, thank you. We're preparing to immunize against influenza already, when the season starts.
Dr. Gann, what is the status of services that Cherokee Nation Health Services are providing now? Are we just emergency services only, or emergency surgeries only? Can you kind of fill us?
I don't have all the
Right now,
details
or-
on that, Dr. Dobbins. It's a little bit outside of my lane.
Okay.
So I refer you to Dr. Jones or Dr. Montgomery. We have cut back on some things because it takes so many staff for immunizations and for testing, as well as the monoclonal antibody infusions that we're giving. So some services have been cut back, but I don't have the details.
Yeah, in case you get phone calls from your constituents and they were concerned about their dental appointment being changed or canceled, or optometry appointment, we're moving personnel into, as Dr. Gann mentioned, into testing and administering vaccines. So we're moving personnel around like we did with the first surge. We moved personnel all over the place. So we're
Yep.
back into that, where basically it's emergency treatments only for the most part. Sean?
Yeah. Dr. Gann, on your state map we had, and that we looked at a lot last year, with the schools, we had yellow, red, and orange, and we followed that close. I think you alluded to it a while ago. Now, that's still based on beds. Is that the case? Our state map red, and I noticed a few orange ones.
Right, so I don't use, different organizations have different color coding schemes. This is from the Harvard Global Health Institute, which is strictly the number of new cases in the last 7 days. So that I don't like the Oklahoma State Department of Health's map because it won't go into the red until there's a certain number of percentage of beds occupied by COVID-19 patients and some other criteria, which I think doesn't help us in our job in public health to take care of the people. That this map is more useful for us.
Just cases, whereas last year, based on beds, or bed was a big part of the.
Right, so you could have, this is, in this scheme, it's 25 cases per 100,000 per day, average over the last 7 days, right? So in the state map, you could have 150 cases per day per 100,000 and still be in the orange because there's hospital beds available somewhere. And so I don't even look at that map anymore. It doesn't help us respond to what's happening
We looked at it a lot
here.
last year.
Yeah, I know.
But yeah, while we got you here, we've all got Dr. Facebook, but I really appreciate you and Lisa being accessible all the time. And I've got a few other things that can wait. Yeah, while we got you here, like, there were 600,000, was that a number of cases, new cases? Now, was that nationwide? Did I get that?
The 6,000 was the number of people Cherokee Nation tested last week.
How about 600? There was one up there.
Right,
The big
so
number, what was that big number?
the global, yeah, so I'd said it wasn't up there, 655,000 cases per day globally.
Globally.
Yes, and that's at a plateau, so
now
it's
with
not changing.
1,000 deaths, right? Is that the same?
The 1,000 deaths per day was in the United States. It was
1,000
just between 900 and 1,000 per day and plateaued. That was
1,000
this
deaths
one.
per day. Wow. One more thing while we got you here. What's the diet of COVID? I've often wondered what, maybe what puts that person in that category, like myself, almost the perfect picture of health, you know, but,
I'm sorry, I don't understand your question.
well, I've always been curious, like myself, I was kidding, the perfect picture of health.
Yeah.
You know, stand to lose, probably 10, maybe. But, you know, if I were to pass away,
Right.
you know, you'd look at, man, high blood pressure, probably, you know, stand to lose. But if I had a trace of COVID, would I be heart attack category, or would I just automatically be mixed up in there in the COVID?
Right, so you're talking about when we determine if someone died from COVID
Not
versus
just you,
with
but just
COVID?
in your profession.
Right, right.
You know, the conversations. I've always been curious about what separates a person if they were unhealthy anyhow, but they did get this, how that figured in our stats of
Right.
they're just a COVID death.
Right, so someone is not considered a COVID death if they happen to have a positive COVID test and die from something else. We look if there's a connection. So of course, you know, you could back that up and say everyone dies from cardiac arrest. Everyone who's ever died, right?
stop.
Because you know, so you try to figure out the proximal cause, you know, for a public health public health reason, right? So when someone has other illnesses, it makes their organs more vulnerable to damage when their body gets challenged by an infection, right? So if someone has very bad heart failure and it's under control, then they get COVID, they don't have to be very sick from COVID for their heart failure maybe to cause their heart to fail and their liver to fail, then they die. So if the question we kind of try to ask is, if they wouldn't have gotten COVID, would they have died then? Okay, and it's not always easy. Now, if someone has pneumonia and their oxygen levels are down in the 60s and they get intubated, then they have a heart attack, they die from COVID. Right? And you can argue it if you want, but this is just a way for us to make definitions to track the impact of the disease. So it's, I said it's not always cut and dry, and the stated definition is like, what's the most proximal cause? Right? So if someone gets in a car wreck and then they break a bone, then that bone gets infected and they die of sepsis from an infection, they died from a motor vehicle accident. But, you know, a death certificate, there'll be 4 or 5 layers there. So died from sepsis as a result of a broken bone as a result of a motor vehicle accident. And then the state has ways to categorize those. Again, so as a public health department, we can say this is the impact of heart disease on our community. That's where we need to go to work. We need to prevent heart disease. So it's not like the answer to a math problem where 2 + 2 is 4, no matter who looks at it, right?
Just doing the best we can do, right?
Yeah, but we make definitions so it's consistent. So when Cherokee Nation says it, the State Health Department says it, and Arkansas says it, that we're defining things the same way.
Thank you.
Yes,
Thank
sir.
you, Chair.
Was that too long of an, sorry.
Anybody? Chief of Staff, did you have something to, just hanging out?
Yeah,
Okay.
sorry, I was having a hard time hearing out there. So
Okay,
forgive me
all
in case there were-
Dr. Gannon, when a constituent comes to us and we recommend they go in to get tested, are they given a rapid test, or do you know what the status on our supplies are on rapid testing?
Sure, there's a nationwide shortage on the rapid testing supplies. Now, rapid test isn't a single kind of test. There's antigen tests, which looks for the protein code of the virus, then PCR, preliminary chain reaction, that looks for the RNA inside the virus. We have both kinds, and right now, because of the nationwide shortage of supplies, we're doing in the drive-throughs mostly the LabCorp test, which is a PCR, which we send to Dallas, mostly to Dallas to get run. And those are coming back in about 48 hours. Some, you know, maybe a small percentage of those we do every day will take another day to come back, and just don't have the supplies. And no one does. They're on order. We got some coming in and some that are promised, et cetera. So
Because we all want to know now.
Sure,
Yeah.
yeah, and that could change tomorrow, next week, it's a moving target, and when we have the supplies, the Abbott PCR rapid test is kind of the preferred thing for the drive-throughs.
Yeah. Any question, Danny?
Yeah, Dr. Gann, we hear a lot about ivermectin. Is that something that people are looking into, or is that just rumors or Facebook rhetoric, or what?
Our patients are using it, and the calls to the Oklahoma Poison Control Center on people hurting themselves with ivermectin are going up. It is not recommended by anyone with a medical degree. Don't do it. You get it from the feed store. So there's no research that shows that it's helpful. There's no guidelines on how much to take, how often to take it. And the last research I read was done on animals, and the amount of ivermectin it took to make a difference in the animals was at a dose that would be toxic to a human. And people are hurting themselves with it. Please don't do it. The FDA has put out really clear recommendations against the using of ivermectin to treat COVID-19.
I do got a question. Todd, you can probably help with this also. So if we have somebody that works for the tribe, and they, let's say the school nurse has to quarantine a class, and our employee, single mom, has to go home with their child, and now she's in contact with someone with COVID. I know the CARES Act has ran out, but are we going to make them use up all their leave and stay home, or are we going to compensate, let them work from the house because everybody's got different ways of reacting to this, and I didn't know where we were going to do to help our employees.
So as much as we can, we try to work with the employees if they can do their work from home. So I've told this body in the past, for almost a little more than a year now, most of the operators that answer the phones for the incoming calls are not sitting here in the complex of the Cherokee Nation. They're actually in their homes, logged in, answering the phone calls. So as much as we can, we'll try to work with those employees and offer them the opportunity to work from home. For those that can't perform their work from home, or we don't have an opportunity, they would have to use their sick or annual leave to take care of a sick child, just like if they had strep throat or the flu or something else, which is unfortunate in the fact that we're kind of in a catch-22 because the state of Oklahoma is fighting schools to not allow mask mandates, which then therefore spreads the virus among the children, which therefore makes parents have to stay out of work, which causes an undue burden on the parents. And so, but we do try to work with every employee as much as we can to provide those opportunities if they're faced with a situation where they're taking care of a kid that's either sick or in quarantine. But I think to answer one of your, if I understood your question correctly, unless that child tests positive, the parent is not a person under investigation or a PUI from a public health standpoint. Listen, Dr. Gann, I expect a pat on the back for that. That came out of there. So they would not be a person that we would put in quarantine at that point in time. They would have to, depending on vaccination status and exposure, and then if the child turns positive, that they would become a person that we would say, hey, you need to go into quarantine status. If all that makes sense, if I answer your question.
But I wish there was something that we could come up with for those that don't have the option to work from home, and if they exhaust all their leave, and then they still have bills to pay, but, I don't know, I wish we could come up with a solution for those employees also. I know the CARES Act really helped us out, but, and sometimes it was taken advantage of,
Yeah, we had some employees that were placed in the quarantine more than 6 times. So if you do that, that's 12 weeks, 3 months that they were not at work at one point in time. So we're trying to make sure that we keep all of our operations functional so that we're there for our citizens as much as we can be. And we believe in the science of the mask and also the vaccination. It's actually worked out pretty well with our workforce, as well as Sequoia High School and the immersion school. So if you got any specifics, there are people that will donate their unused sick leave to try and help out as much as possible. So if there's an extreme circumstance, please let me know, and we'll see if we can't work something out.
Okay, thank you, Dr. Gann. Thank you, Ms. Pivek. Oh, looking old business, none, I see. No new business. Any announcements? I'd see that the next meeting is tentatively scheduled for Thursday, October 28th at 11 a.m. Entertain a motion to adjourn. And a second. Okay.